Hi, this is a 25 years old patient presented to me with aphakia and severe iris damage after repair of corneoscleral laceration. I started the surgery by doing anterior vitrectomy to clean the vitreous that was present in the anterior chamber. And now I'm gently stretching on this fibrotic iris that was retracted into the angle of the anterior chamber. And while doing this stretch, I realized that the iris tissue was very stiff. So I was doing this stretch very gently in order to avoid this insertion of the iris root. Now I'm repeating this step at different locations, trying to get the maximum amount of iris tissue to work with in order to reconstruct the severely damaged iris. Now I'm creating an intrascleral Hoffman pocket using a crescent blade. Through that pocket, I will pass the two arms of a double armed 10-O proline suture on a straight needle guided by a 27 gauge needle in order to attach the root of the iris to the sclera. And while passing the straight needle through the paracentesis, I do a side by side movement in order to make sure that the needle is not catching any corneal tissue. Now I am retrieving the two ends of the suture through the Hoffman pocket. Then I performed a single pass force through pupilloplasty by passing the straight needle of the 10-O proline suture through the paracentesis, then into the iris tissue, and externalizing it from the other side, guided by a 27 gauge needle. After externalizing a loop of the suture through the paracentesis, the end of the suture will be passed 4 times through that loop. Then I will pull on the two ends of the suture to tighten the knot. Now I am tightening the two ends of the suture that were externalized through the Hoffman pocket in order to attach the root of the iris to the sclera. Now it's a time for aphakia management by performing the Yamane technique. After placing two limbal marks 180 degrees apart, I placed the other marks 2 mm back from the limbus, and I am now injecting a 3-piece IOL into the anterior chamber. Now I am externalizing the leading haptic. After externalizing the leading haptic and making its flange, I introduced the trailing haptic into the anterior chamber in order to externalize it. Now I'm pushing on the flanges to make sure that they get inside the scleral tunnel, and at the end of the surgery, I injected diluted triamcinolone to check for any vitreous, and I found vitreous protruding through the main incision that was removed by the vitreous cutter. Thanks for watching.